Alrighty, thank you for joining this webinar on colorectal cancer and your risk and how it impacts screening, presented by the Certified Genetic Counselors of Middlesex Health Cancer Center. We're very excited to share this presentation to help keep our community healthy. So without further ado, I am going to turn the presentation over to our first genetic counselor who will be presenting, and that's Kelly Watrous. Kelly, go ahead.
Thank you, Amber, and thank you everyone for joining. My name is Kelly Watrous, and I'm one of the 3 cancer genetic counselors at Middlesex Health. We're excited to be giving this presentation tonight on a topic that we feel to be very important. So there is a spectrum of risk for colorectal cancer, and what your risk is really directly correlates with what your screening plan should look like. Personal history, family history, and genetic testing can all play into this. So tonight we hope to give you a good overview and also to provide you with a plan for how you and your family members should really be thinking about risk. It's so important to be proactive and for the early detection of cancer. So with that, I'll jump right in. We wanted to start with some GI anatomy. So your intestines include your small intestine and your large intestine, and the colon specifically refers to the large intestine. The colon itself has several parts, which you can see labeled here, and it's important to note that polyps and cancer can really develop anywhere along your colon. So when you go for a colonoscopy, a scope is passed through the rectum and all areas of the colon are checked. So while anyone can develop a colorectal cancer, risk really does increase with age. Colon cancers rarely develop in a child or a young adult. Typically, the main risk is in the later decades of life, as you can see depicted in the graphic on the right. There is some difference in men versus women. So 4.4%, which is 1 in 23 men, and 4.1%, which is 1 in 25 women, will be diagnosed with colorectal cancer in their lifetime. Rates are 30% higher in men than in women. And the median age at diagnosis is in the 60s. So age 66 in men and 69 for women. Of note, the median age is definitely getting younger over time. So historically, the recommended age for screening colonoscopies in the average risk population was age 50. But in recent years, this has lowered to age 45, and it's even lower than that in high-risk groups, which we'll talk about tonight. So if you've ever wondered what a polyp looks like, on the left, we have a graphic of an actual colon with polyps. So normal colon tissue is smooth with ridges, and then polyps are these ground growths that you see here on the left. During a colonoscopy, your doctor would cut these out and send them to pathology to be looked at under a microscope. Colorectal cancer almost always begins as a polyp. So in the cartoon image on the right, you can see what that progression looks like. Things start out as benign polyp tissue, and over time, abnormal cells can develop, which, if they're left alone, can multiply and spread even beyond the colon wall. So the goal here really is to identify and remove polyps before they have a chance to progress. In some people, this progression might take 10 years. Other people, it might only be a year or two. So back to our theme of the night, where knowing your risk level is really key to getting proper screening. All polyps are not created equal. Polyps themselves are very common, found in about half of average risk individuals 50 years and older who are undergoing colonoscopy. Fewer than 10% of polyps progress to invasive cancer, and this is a process that usually occurs slowly over 10 to 20 years in most people. This process happens faster if polyps are larger, if there's more polyps, or if you have other risk factors, which we'll go over. Polyps are classified based on their growth pattern. So adenomas or adenomatous polyps are the most common cancer precursor. These are the types of polyps we want to pay the closest attention to. The other type of polyp is serrated or hyperplastic. These typically do not develop into cancer. They can, but typically they do not. So it's very important when you're collecting your own history as well as the history of your family members that you're clarifying not only the type of polyp, but also the total number of polyps found in the colon. So you could ask your doctor, how many polyps did I have, or how many adenomas did I have, to try and clarify that information. This information is also found on your pathology report from your colonoscopy. So if that's something you have access to in your electronic medical record, for example, you can look for those key details. Again, the type of polyp, whether or not it was an adenoma, and then the total number of polyps. So, excuse me. Now that we've talked a bit about colorectal cancer and colon polyps, I wanted to shift gears a bit to review some symptoms of colorectal cancer. So early cancer may actually have no symptoms, but there could also be any of the following. There could be rectal bleeding, blood in the stool or the toilet, dark or black stools, change in somebody's bowel habits or the shape of the stool. Typically, there's narrowing of the stool. There can be cramping, pain, or discomfort in the lower abdomen, the urge to have a bowel movement when the bowel is empty, constipation or diarrhea, decreased appetite, unintentional weight loss, and then even unexplained anemia can be a sign of colorectal cancer. If you're having any of these symptoms, it's so important to ask your doctor if a colonoscopy would be an appropriate next step. Like all areas of your health, it's so important to advocate for yourself. Just because you're young or appear to be in a low risk category doesn't mean you can't get colorectal cancer. It might be less likely, but it doesn't mean it can't happen. People in their 30s get colorectal cancer, and people with no family history get colorectal cancer. So this is a good list to file away in the back of your mind. There are some clues that a person may be at higher than average risk for colorectal cancer. So when it comes to risk factors for colorectal cancer, there's two main categories. The first being risks that are modifiable or more lifestyle based, and then the second group being risks that are non-modifiable. So in the United States, more than half of all colorectal cancers are attributable to lifestyle factors. And the biggest four at play here are unhealthy diet, physical inactivity, high alcohol consumption, and smoking. The other category is non-modifiable risk factors, and these are related to heredity and medical history. Excuse me. So we'll break each of those down a bit more. The first category I mentioned is modifiable or lifestyle based. And numerous studies have shown that people with healthy lifestyle behaviors have a 27% to 52% lower risk of colorectal cancer compared to those without these behaviors. So that's a pretty powerful statistic, and it really shows how a huge portion of risk is actually within our control. So physical activity, for example, is strongly associated with a reduced risk of colon cancer. On the other hand, obesity increases the risk of colorectal cancer, as does a diet high in refined carbs, processed sugar, red meat. These all have a higher potential to increase inflammation and are associated with increased colorectal cancer. And the last two here regarding cigarette use and alcohol consumption, some more powerful statistics. 12% of colorectal cancer is thought to be attributed to cigarette use, either current or former smoking. Colorectal cancer risk in current smokers is about 50% higher than that in a never smoker. 13% of colorectal cancers in the US are attributed to alcohol consumption. So heavy drinking, which is defined as more than 3 drinks a day, is associated with a 25% higher risk. And certainly we're not claiming any of these are easy changes, but there's absolutely so much of our risk that's within our control. And like I mentioned, that's a powerful thing. So even making some lifestyle modifications can help your risk level. So that's the first category of risk, modifiable or lifestyle based. And the other category of risk is non-modifiable. So this is broken out into medical history and family history. So for medical history, you'll notice that word again, adenomatous. If you have a history of adenomatous polyps, especially multiple or large polyps, if you have a personal history of colorectal cancer, you're actually more likely to develop a subsequent colorectal cancer in your lifetime. So just because you've had colon cancer once doesn't mean you're off the hook, unfortunately. If anything, it means you're more likely to have another. People with inflammatory bowel disease, which includes ulcerative colitis and Crohn's disease, have almost double the risk of developing colorectal cancer compared to people in the general population. So if you have one of these or you know somebody with Crohn's, for example, you may be familiar with that these people go for more frequent colonoscopies. People with type 2 diabetes also have increased risk of colorectal cancer, as do people who've had a personal history of childhood, adolescent, or young adult cancer that was treated with chemotherapy or radiation therapy. A non-modifiable category of family history includes if there's a family history of colorectal cancer, and also if there's a family history of adenomatous polyps. So hopefully that'll be a takeaway from tonight that just as much as colorectal cancer history matters, it really matters if there's a polyp history in either yourself or your family as well. And then if there's a hereditary cancer syndrome in the family, that would affect risk as well. So while these are things that we can't control, we do have control over whether or not we, number one, know this information about ourselves and our family members. So asking questions. And then second, if we communicate this information to our doctors. So our doctors and our medical providers can only take the best care of us if they have the whole picture and they have all the information. So that's, certainly on us to an extent to make sure that they have that information, both about us as well as our families. So at this time, I'll turn it over to Amanda, who will dive more into the family history piece and how that impacts screening.
Hello, thank you, Kelly, for introducing us to colorectal cancer and risk factors. I am Amanda, and I am one of the genetic counselors in the Cancer Center at Middlesex, and I'm going to discuss really how family history can impact our risk. So kind of thinking about the non-modifiable risk factor here. The impact of family history on our risk for colorectal cancer really depends on the reason that our relatives or a relative developed colorectal cancer in the first place. Most colorectal cancers are the result of many small risk factors that come from our environment, maybe things in our environment that we're not even realizing are increased risk factors, our lifestyle, as well as small genetic factors. And so when a group of these small risk factors come together, the cancer can develop. And this is why most cancers happen later in our lives, in our 60s, our 70s, our 80s, because it takes that long in our life to accumulate enough of these risk factors that the cancer develops. And so when we think about risk, then we refer to this type of cancer with these small risk factors as multifactorial. And that's exactly what it sounds like. It's cancer as a result of multiple small risk factors. When cancer in our family has a multifactorial cause, we actually will have some increased risk for that type of cancer. And that's because family members have similar risk factors, whether they're environmental risk factors or lifestyle risk factors or small genetic factors. So if one person in a family had enough of these little factors that they developed a certain type of cancer, other family members probably have some of those little risk factors too, which is going to give them an increased risk for that type of cancer. So as you can see, looking at this graph here, this graph is comparing cancer risk in people with a family history to people without a family history. And the top line is showing cancer risk for people with a family history. And you can see that that risk is higher than people without a family history. You can also see, interestingly, that the risk starts to go up at younger ages. So that bottom line is looking at age that people develop cancer. And you can see that people with a family history's risk to develop colorectal cancer starts to go up at a younger age than people without a family history. And so really, what we know is that individuals who have a close family member with colorectal cancer that is the multifactorial type, because of those shared risk factors, they probably have about a double risk to develop the colon cancer in their lifetime. So as Kelly mentioned before, the risk to develop colorectal cancer in the United States is about 4%. So anybody who has, say, a parent or a sibling or a child with a history of colorectal cancer, instead of having a 4% risk to develop colorectal cancer, likely has an 8% risk. So I mentioned that the effect of family history on our risk for colorectal cancer depends on the underlying reason that the colorectal cancer developed in our relative. And so we know that actually about 90% of colorectal cancers are the multifactorial type. But about 10% of colorectal cancers are hereditary. And hereditary risk is associated typically with a much higher lifetime risk of developing certain types of cancers. So one type of hereditary colon cancer is called Lynch syndrome. There are many types of hereditary colon cancer. Lynch syndrome is the most common. And as you can see on the left-hand side of this slide, that individuals with Lynch syndrome actually have a lifetime risk for colorectal cancer of between 45 and 60%. So obviously much higher than that average risk of 4%. We also know that individuals with Lynch syndrome or hereditary cancer risk can develop cancers at much younger ages. We can see colorectal cancers in people's 20s or 30s when they have Lynch syndrome. In addition, we know that in the United States, about 1 in 300 people have Lynch syndrome. So it's actually much more common than we would think. Hereditary cancer, like Lynch syndrome, is due to a genetic difference or a mutation that exists and is inherited from generation to generation in a family. And most often is inherited in what we call an autosomal dominant way. That means that both men and women are just as likely to inherit the mutation or the hereditary cancer risk, and that if someone has the mutation or hereditary cancer risk, each of their close family members, like their siblings, have a 50-50 chance to also have that mutation associated with that increased risk. Interestingly, this means that some family members will actually have the high risk, while other family members will have average risk. So if we look at the family to the right, you can see at the top there's a couple, and the father is kind of a tan color and the mother is a bluish gray color. The mother has a mutation that's causing increased cancer risk. So that means that each of her children have a 50-50 chance to inherit that mutation. And in this diagram, you can see that her daughter on the left did not inherit the mutation or the hereditary cancer risk, but her son on the right, who's the bluish gray color, did inherit that mutation. What that means is that the son, if it was Lynch syndrome, has that elevated risk and has a 45 to 60% lifetime risk of developing colorectal cancer. While the daughter on the left, since she did not inherit that mutation, she's actually at average risk, or the 4% for colorectal cancer, because she did not inherit that mutation associated with hereditary cancer risk. So, how do we recognize hereditary cancer syndromes in families? Well, we actually use the family history to give us clues about whether colorectal cancer in a family is multifactorial or hereditary. These clues that are listed here on this slide are really important to determine whether or not it could be hereditary cancer that's causing a cancer in the family. One of the things that we know is that since hereditary cancer is caused by a mutation that's inherited from generation to generation, individuals who inherit that change have it from birth. That means that those individuals have that risk factor from the beginning, which is different than multifactorial cancer, where you need to accumulate those risk factors over your lifetime. So one of the most significant things we see in hereditary cancer syndrome families is that people oftentimes can develop their cancers at younger than usual ages. We can also see multiple people in the same family with the same type of cancer or related cancers. And we can see multiple generations affected because that mutation is being inherited from generation to generation. So we might see cancer in a grandparent, a parent, a child. And the other thing that we can see are people developing more than one cancer. If we have a mutation that we're born with that is putting us at increased risk for cancer, say colorectal cancer, and someone develops a colorectal cancer and it's treated, that person still has that mutation and it has a much higher chance of developing a future colorectal cancer, even after they've had their first colorectal cancer. So when we see these signs of a potential hereditary cancer syndrome in a family, then we think about doing genetic testing, which can be done on a blood sample or using a saliva test. And this is what's used to figure out if a history of cancer in a family could be hereditary cancer. If we identify that it is hereditary cancer in a family through genetic testing, we can then go on to use the genetic testing on other family members to figure out who inherited the mutation in that increased cancer risk and who did not. It is important to note, with so much genetic testing available these days, that genetic testing through companies like 23andMe do not fully evaluate for hereditary cancer and should not be used to determine if a family history is due to hereditary cancer. So hereditary cancer can really only be identified, though, then if you know your family history and you know if these clues are in your family, and then if you share it with your providers. One study found that 22% of people with colorectal cancer didn't have enough information in their medical chart to determine if it could be a hereditary cancer syndrome that caused their colorectal cancer. So it's really important to share family history with your medical providers in order to determine whether or not you could be at risk for hereditary cancer. So how does it help to know whether cancer is multifactorial or hereditary? And really, the way it helps is allowing providers to match your level of screening to your level of cancer risk. Individuals with Lynch syndrome who have greater than a 50% chance of developing colorectal cancer in their life are going to need very different screening than someone who has average risk, or 4%. So really, when we think about screening, we think about colonoscopies. They are one method that's used to screen for colorectal cancer. Screening with a colonoscopy actually does two things. It screens for colorectal cancer, but it actually helps to prevent developing colorectal cancer as well. And it prevents the development of colorectal cancer by finding and removing those polyps that Kelly was talking about. If we find them and we remove them, they never get a chance to become colorectal cancer. And that allows us to decrease the chance of someone developing it and increase the chance of someone having a cure if they were to develop colorectal cancer by getting this screening done. Unfortunately, many times we don't have all of the information, or our providers don't have all of the information that they need about our family history to determine what's the best colonoscopy screening recommendations and management for us. So it means that it's very important for individuals to share information with their providers to make sure that they are getting that right screening. So this is an example of screening by risk level. So as Kelly mentioned, now in the general population, we start colorectal cancer screening at the age of 45. Typically, it's done every 10 years. And again, because Kelly mentioned, it typically takes a polyp about 10 years to turn into cancer. So if we do the colonoscopies every 10 years and take out the polyps, we can effectively reduce the chance that person would develop colorectal cancer. But if someone has multifactorial risk, and that risk is a little bit higher, it's say 8% instead of that 4%, then we oftentimes start colonoscopies at the age of 40 instead of 45. If someone has a family member who had colorectal cancer even younger, then we may start the colonoscopies younger. And if someone has hereditary cancer risk, we oftentimes start colonoscopies even younger at age 20 and do them every year. So our colonoscopy screening really does have to match to our level of risk. It's important to note that there are other types of screenings. Colonoscopy is not the only thing that exists. There is one type of screening called Cologuard. And Cologuard is a screening test that's appropriate for people at average risk. It is not for individuals with a family history or for individuals with hereditary cancer risk. Cologuard screens for colon cancer, but it does not take out polyps. So it does not reduce our chance of developing colorectal cancer, but it does screen for it. So the question is, well, who makes up these guidelines, and how do we know that these are the most appropriate guidelines for us? And this is an example of an existing guideline that's put out by a group called the National Comprehensive Cancer Network. And this shows where some of this information comes from. So in this guideline, it's looking at family history criteria and saying that if someone has a first-degree relative with colorectal cancer at any age, we start colonoscopies at the age of 40. And so that's really where that criteria came from. If you look at the bottom one, you can see that somebody who has a close relative with what we call advanced adenoma, which is a larger polyp, one that's a centimeter or bigger, or one that shows some differences in it, they also meet the criteria to start a colonoscopy at age 40 instead of age 45. And so what that means is that even individuals with no family history of colorectal cancer, but do have a family history of adenomas of a certain type, may still need earlier and closer screening, even though they technically do not have a family history of colorectal cancer. So what do you need to know to find the right screening for you? Well, what do you need to know about yourself? You need to know, have you ever had any adenomas? And if so, how big were they? And what is the total number of adenomas you've had over your whole life? Do you have a personal history of inflammatory bowel disease, cystic fibrosis, or treatment for a cancer when you were younger, in childhood or as an adolescent or a young adult? What do you need to know about your family? You need to know, has anyone in your family had colorectal cancer? And if so, who and at what age? You also need to know who in your family, particularly first-degree relatives like parents and siblings, who's had adenomas. How old were they when they had adenomas? How many total adenomas have they had? And have they had any advanced or large adenomas? If you know and share this information with your providers, it can determine, number one, if you need genetic testing to see if you have hereditary cancer risk. And number two, it can determine, do you have enough multifactorial risk that you need different screening? Thank you so much. Now I'm going to turn it over to Heywan, who's going to give some more examples of how assessing risk can tell us how to screen someone.
All right, thank you, Amanda. So my name is Heywan, and I'll be going over some examples to illustrate what we discussed in terms of different levels of cancer risk and how families should be screened differently based on the risk level. So the first example is illustrating hereditary cancer risk. So to help you get oriented looking at the family tree, the circles represent females and squares represent males. Different colors represent different types of cancers, and deceased family members have diagonal lines over them. So our patient is shown here with a black arrow next to it, and she was seen because of her family history. So her mother was diagnosed with colon cancer at age 58, and her mother's sister was also diagnosed with colon cancer at 47, as well as ovarian cancer at 42. And their mother's father had stomach cancer at 53. So this family tree does show some of the features of hereditary cancer syndrome that Amanda mentioned earlier. So for example, the patient's maternal aunt had multiple primary cancers, and both cancers were diagnosed at a young age, before the age of 50. And there is the same type of cancer, in this case, colon cancer, in two relatives. So our patient's mother underwent genetic testing based on her personal and family history, and her results came back positive for a MSH2 mutation associated with Lynch syndrome. Therefore, our patient had a 50% chance of either inheriting that same MSH2 mutation from her mother or not inheriting the mutation. And when she moved forward with genetic testing, her results also came back positive for Lynch syndrome. So Lynch syndrome is characterized by increased risk of developing some of the cancer types shown here, such as colon cancer, ovarian cancer, and stomach cancer, but it can also increase the risk of developing other cancer types not shown here, which includes uterine cancer, bladder cancer, small bowel cancer, and other cancer types. The average risk of developing colorectal cancer in the general population is about 4%. With this MSH2 mutation, the risk is elevated to about 33 to 52%. And based on the national guidelines, individuals with MSH2 mutation can start colonoscopy screening as early as age 20. So our patient, who's 42 years old, needs to start colonoscopy screening now, and it needs to be repeated every year. So she's at increased risk of developing GYN cancers, including ovarian and uterine cancer. So she's recommended to meet with specialists to discuss risk reduction options, which may include imaging to prophylactic surgery. And again, there are other cancer types associated with Lynch syndrome. So she needs to work very closely with her providers to discuss appropriate screenings. Our patient also has a son who is 28 years old. He needs genetic testing to see if he also carries the MSH2 mutation. And if he does, then he would also need to start colonoscopy screening now. And the patient needs to inform other family members on her mother's side about the MSH2 mutation so that they can go through genetic testing and see if they need to be screened differently. So this example is illustrating a family history of colon cancer without a genetic mutation. So our patient is shown here once again with a black arrow next to it. So she has a father with colon cancer at age 65, as well as a paternal grandmother with colon cancer at 48. Our patient underwent genetic testing based on her family history, especially because of the early onset colon cancer in her grandmother, and her results came back all normal. So no genetic mutation was identified. But just because her results came back normal does not mean that there is no genetic mutation in the family. So it's possible that her paternal grandmother could have carried a mutation, and maybe her father also carries a mutation, but we just don't know because they never had genetic testing done. So there could be a genetic mutation in this family that our patient did not inherit, and therefore her genetic test results came back all normal. But there is also a possibility that this family truly doesn't have a genetic mutation and could be just consistent with multifactorial etiology contributed by environmental factors, lifestyle factors, etc. So for our patient, just because her genetic test results came back all normal doesn't mean that her risk for colorectal cancer is the same as the general population risk. She still has a father and a paternal grandmother, so 2 relatives with colon cancer. So her risk is still higher than the general population risk. And the screening recommendation for people with a first-degree relative with colon cancer is to start colonoscopy screening at age 40 or 10 years before the earliest diagnosis of colorectal cancer in the family, and to repeat it every 5 years at minimum or more frequently if there are positive colonoscopy findings. So for our patient, she's 34 years old, but she should start colonoscopy starting at age 38 because the earliest colorectal cancer in the family was at 48, and she needs to repeat colonoscopy at minimum every 5 years. So the bottom line is that even though her genetic test results came back all normal, she still needs to start colonoscopy screening at an earlier age and have it done a little more frequently than what's recommended for the general population because of her family history of colon cancer. And this recommendation also applies to her siblings, so to her 2 brothers. And her paternal aunt and paternal uncle should already be having colonoscopy done based on their age, but they should also be having one done at minimum every 5 years based on their family history. And this last example is illustrating a family history of colon polyps. So here we have a patient with a personal history of multiple colon polyps. She's developed 25 adenomatous colon polyps. So she underwent genetic testing and her results came back all normal. And so based on her test results, the exact cause of why she's developed so many adenomas is still unknown. But based on her personal history of 25 adenomas, the recommendation is to continue colonoscopy every 1 to 2 years. And she also has 4 children, so 3 of them are in their 20s, and she also has a daughter who's a teenager. And so based on our patient's history of multiple adenomatous colon polyps, her children they're actually recommended to start colonoscopy earlier as well. And according to the national guidelines, colonoscopy can be considered beginning in late teens and repeating every 2 years when there is a family history of 20 or more adenomas in a first-degree relative. So her children, despite their young age, they all qualify for screening based on their mother's history of adenomatous polyps. And so this example shows that even if there is no reported history of colon cancer, and even if there is no genetic mutation, based on the type of colon polyps, so adenomas, and the number of colon polyps, screening recommendations can change drastically in a family. So the overall goal of everything that we discussed tonight is really to be preventative and to be proactive about our health, to prevent cancer from happening in the first place, or if it were to happen, to find it as early as possible and to treat it as early as possible. That's really the goal. And in order to achieve this goal, it's important to know what's present in our family. So what types of cancers are present, when family members were diagnosed, how many adenomas are present. And it's important to share this information with providers so that we can provide the best care for you. And our role as a genetic counselor is to assess your family history, your personal cancer risk, see if genetic testing is appropriate, and to be able to offer you specialized screening based on your personal and family history. So on this slide, we included a little bit of information about our program. So we provide risk assessment for all cancer types. We have 2 locations, one in Middletown, one in Westbrook. We do take self-referrals. And when genetic testing is indicated, it's generally covered by insurance. But if it's not covered, then current out-of-pocket cost is about $250. And you can contact us at the number provided. So I really hope you found all this information to be helpful, and we are open to questions if you have any. Thank you.
All right, well, we give another minute or so for questions. Thank you, first of all, to Heywan, Kelly, and Amanda for this amazing presentation, packed with useful information, and presenting how colorectal cancer risk is not so black and white necessarily, and your screening recommendations may be tailored based on your many factors, including your family history. So to that point, I think you all did a nice job in bringing home the fact that we need to be sharing information with our providers so that they can help us make the most informed decisions about our care. But along with that, I want to emphasize how important it is to talk with your family members. This was kind of referenced throughout the talk. It may not be top of mind or the thing you're most excited to talk about at the dinner table when you gather with your family. But it is so important to share that family history because it can impact not only your health, but the health of and recommendations, as we learned, for family members around you. So don't be shy in talking about your colonoscopies, your adenomas. So important to share that information, even if it's not necessarily the most exciting thing. It goes a long way in helping to keep your family healthy as well. All right, so I'm not seeing any questions come through. So again, I just want to thank our 3 genetic counselors. We're very lucky at Middlesex Health to have a very robust team of genetic counselors. Our team is larger than many at some of the larger centers. So that's part of our commitment at Middlesex Health to prevention and early detection of cancers, which is just so important. So we're very happy to have all of you on staff and to have this wonderful talk. So thank you all.
Thank you, Amber.
Thank you.
Amber.